Hello, everyone. My name is Christian Diaz, and I'm going to talk about Ledipasvir and Sofosbuvir for 8 or 12 weeks for chronic and HCV without cirrhosis. Definition: Sofosbuvir is an inhibitor of the analog polymerase nucleotide, and Ledipasvir is an inhibitor of the replication complex NSSA of HCV in combination used to treat chronic hepatitis C with or without cirrhosis.
The last 9 months or so has seen a dramatic change in the way we treat hepatitis C in this country. Of course, it's now a disease which can be effectively cured in almost all patients, and it can be treated with a short course of medicines, and hence ideally suited for treatment in primary care. So there's my conflicts of interest. I don't need to remind you that this has been a silent epidemic of the last century. We think that around 150 million people are infected, and around 250,000 in Australia and 50,000 in New Zealand. And that data is fairly robust on prevalence studies, and the number of people we see who die from hepatitis C, you can work out exactly what the overall prevalence is in New Zealand. So if you think about 50,000 people are living with hep C currently. A lot of the impetus to fund better management of hepatitis C came about as part of Peter Hodgson's response to the bad blood debacle with people being infected through transfusions. And you're well aware that although the virus was discovered in 1989 and an antibody test made soon after that, screening wasn't introduced here until 1992. Hence, a number of people were infected during that 3-year period, and this led to the government putting resources into hepatitis C. I should say, however, that transfusion-acquired hep C now is really an uncommon event. We still occasionally pick up patients, mainly have been transfused overseas. Almost all the people we see now have been infected through recreational drug use, mainly injecting drug use, in their teens and 20s. Most of the people we see have been clean for 20 or 30 years.
Applications in medicine. The doctor should be careful to manage Harvoni and combine it with Sovaldi and Daclinza in patients who are in pre-treatment with Amionodora, since there have been reports of several bradycardia and heart block. When administering these drugs in combination, you should monitor the patient the first weeks of treatment to observe side effects.
So this is the algorithm for patients you see with hepatitis C. So you're going to test them with the reflex testing. You're told that they're RNA positive. You're going to do a FibroScan to see whether they have cirrhosis or not. If they have cirrhosis, they should be referred to secondary care, where they'll need long-term follow-up. If they don't have cirrhosis, then these are patients you could potentially treat in your practice, and we would encourage you certainly to discuss with the local clinic if you want support on that. If they're genotype 1, they already have pharmac-funded treatment from the 1st of October. That has a high cure rate, and those patients don't need any further follow-up. If they're negative 12 weeks after they finish treatment, they can forget about their hep C. It will never come back. What though if they're the 40% or so who don't have genotype 1, they have genotype 2, 3, 4, 5, or 6? Those patients, there's currently no funded oral treatment by pharmac, and we suggest that they have an annual review. And I would certainly hope that we're going to have treatment for those patients before the end of this year. I'm being an optimist, but I certainly know that pharmac are very keen to get the new pangenotypic treatments across the line as soon as possible. But there is currently another route for them to access treatment. There are some pangenotypic treatments available overseas, and patients can self-fund and self-import generic direct-acting antivirals, and they may ask you about that. And these do work. There's instructions how you do this on all those documents I showed. The BPAC document has a step-by-step how you access that. It is allowed by MedSafe. They're not allowed to say they encourage it, but it is allowed by MedSafe and by Pharmac, and they were involved in.
Pros and cons. Pros: combining Ledipasvir, Sofosbuvir show positive results for the cure of hepatitis C without cirrhosis, curing these thousands of persons in the world. Cons: the most common side effects that may occur include fatigue, headache, nausea, diarrhea, insomnia. Issues applying in Ecuador. In Ecuador, hepatitis C prevalence is low, but according to studies, in Ecuador's 70% of the adult population had hepatitis, with only 10% show with clinical symptoms, and the rest did not show a discernible picture. Conclusion: having done this research and concluded that treatment with Ledipasvir, Sofosbuvir for 8 weeks orally once daily for chronic hepatitis C without cirrhosis is very effective and has had a high rate of virologic response sustained. Thank you.